Hello and good evening, everyone. Welcome to our 95th Blue Hills Virtual Seminar. Blue Hills Virtual Seminar is a platform that allows healthcare professionals to discuss current management updates of different health-related topics for better patient care. And this platform is brought to you by Blue Hills Ethiopia. It is sponsored by Ankara Technologies for the Laimnat project with Blue Hills Ethiopia today. So Getnet project, the comprehensive platform dedicated to offering valuable information on pregnancy, childbirth, and the initial stages of childhood development, catering to both the parents and expectant mothers. Additionally, Getnet offers the convenience of doctor consultations for individuals seeking professional advice. Moreover, Getnet features a marketplace that showcases a diverse range of maternity-related products, providing a one-stop solution for the needs of expectant mothers and parents. So Getnet has entered into a collaborative partnership with Blue Hills Ethiopia with the primary objective of enhancing the expertise and knowledge of Getnet's medical professionals, particularly focusing on the intricacies geared towards providing specialized training and upskilling opportunities for doctors associated with Getnet, ensuring their aware of obstetrics and mother care. So Blue Hills Ethiopia is a medical consultancy company founded by medical doctors and a computer engineer, and we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge and preventive medicine. And I'm your host, Dr. Henot Adela, a general physician and first aid trainer from Blue Hills Ethiopia. Today, it's a pleasure to have Dr. Getnet Alemayew here with us to have a presentation on antepartum hemorrhage. Dr. Getnet Alemayew is an assistant professor of gynecology and obstetrics at Arba Minch University. He completed his residency program in gynecology and obstetrics from St. Paul Hospital, Millennium Medical College. Dr. Getnet, the stage is all yours. You can begin.
Thank you. I would like to thank Blue Hills Ethiopia to prepare such kind of presentation. So I'm Getnet, and I'm trying to present one of the obstetric emergencies that we are going to face when we attest during the OBGYN wards. So these are my table of contents. So I will try to discuss about pregnancy-related hemodynamic changes and the three most common causes of antepartum hemorrhage. So during pregnancy, so we will find there are different physiologic changes that we face. So one of it is plasma volume expansion. So around during pregnancy, we will expect around 40 to 15% increment in the plasma volume during pregnancy. And the other physiologic change is increasing the RBC mass by 20 to 13%. And also the maternal cardiac output also increased, and the systemic vascular resistance also falls. And there is also the hypercoagulability state. So this all five changes will be protective mechanisms, especially during delivery. So as commonly we found some moderate minimal amount of vaginal bleeding after delivery. So these protective mechanisms will compensate such kind of changes, hemodynamic changes. Can I go to the next slide? So this graph, this slide shows a relationship among the systemic vascular resistance, the blood pressure, and the cardiac output during blood volume deficit. So this red line shows the systemic vascular resistance, and the green line the cardiac output, and the blue line will show the blood pressure. So on the x-axis, as we just try to see on the x-axis, there is a blood volume deficit in percentage and the percent control on the y-axis. So after delivery, we will find around 10%. When there is a 10% volume deficit, blood volume deficit, the systemic vascular resistance will try to increase and blood pressure and the cardiac output will be maintained, but the blood volume deficit will be increased, like it's reached around 20%. The systemic, even if the systemic vascular resistance will increase, we couldn't maintain the blood pressure and the cardiac output, and finally the patient will go to the shock. And the increment in the systemic vascular resistance couldn't even maintain the normal blood pressure and cardiac output, and finally the patient will end up in the hypovolemic shock. So there are 5 classes of hemorrhage. 4 classes of hemorrhage, depending on the amount of blood loss and the percentage of loss, and there is also each class have its own physiologic response for the volume deficit. So this volume deficit, this class of hemorrhage is just for the normal 17 kg pregnant woman, which we estimate to have around 6 liters of blood volume. So depending on the loss, there are 4 classes: class 1, class 2, class 3, and class 4. So this class of hemorrhage will help us to estimate the blood loss during the initial patient assessment. And recognition of the severity of the loss is also important crucial for our management, because obstetrics hemorrhage. So the visual inspection will undermine the the exact amount of blood loss, and even some cause of obstetric hemorrhage that also might be concealed one. So we couldn't get the exact amount of blood loss. So generally, knowing the physiologic response for each class of hemorrhage is important to estimate the loss and to manage the patient accordingly. So in class 1 hemorrhage, we say when there is a loss of around 50% blood loss. So in such kind of patients, they will have dizziness, palpitation, and blood pressures also will be maintained on class 1. So in class 2 hemorrhage, the loss is around 20 to 25%, and here the patient may have signs of tachycardia, tachypnea, sweating, weakness, and narrow pulse pressure, and finally they will develop orthostatic hypotension on the class 2 hemorrhage. And on class 3 hemorrhage, the loss is around 30 to 35%, and the patient will have a significant tachycardia, tachypnea, and restlessness. While included extremities will be found on class 4 hemorrhage. Here the patient will have shock and multi-organ failures, and will be developed. Here the loss will be around 14%. So generally, it's important to know such kind of class of hemorrhage, and it's important also for the management preference. Now I will try to proceed to our today's topic. So it's antepartum hemorrhage. So it is the bleeding which occurred during the second half of pregnancy, especially in our setup after 28 weeks of gestational age, or after the age of fetal viability. So if you found bleeding after 28 weeks of gestational age up to the delivery of the last fetus, so we'll call it antepartum hemorrhage, and it's account around for 2 to 3% of all pregnancies. So it's one of the obstetric emergencies that you are going to find on the rotation. And there are different causes of antepartum hemorrhage. And it can be obstetrical causes or non-obstetric causes. Okay. So these are the common causes of third trimester bleeding. So it can be obstetric one or it can be non-obstetric one. So the obstetric cause of hemorrhage can be blood issue, placenta previa, placental abruption, vasa previa, PIC, and uterine rupture. And the non-obstetric causes, there are local causes like vaginal infection, local causes like cervical polyp, cervicitis, cervical cancer, and dysplasia, vaginitis, leech infestations. These are the non-obstetric cause of third trimester bleeding. So of these, blood issue, abruptio placenta, placenta previa, and vasa previa are the most common ones. So I will try to discuss on the abruptio placenta, placenta previa, and vasa previa on the next few slides. So the abruption, so it's defined as a premature separation of normally implanted placenta from the normal uterine attachment site after 20 weeks of gestational age, but we say it should be before the last delivery of the last fetus. So it accounts for 1/3 of third trimester vaginal bleeding, and of some 40 to 6% of abruption will occur prior to 37 weeks of gestational age. And the overall incidence is 1 in 100 births. And depending on the extent and intensity of placental separation, it's the most significant cause of perinatal and maternal mortality during pregnancy. So abortion is characterized by defective maternal vessels in the decidual vasalis, and on rare occasion, the separation might be due to disruption of the fetal and placental vessel. So this disruption will damage the vessels and cause decidual hematoma, which promotes further the placental separation and destruction of the placental tissue, and loss of maternal fetal surface area for nutrition and gas exchange will be affected. So there are some risk factors, but the primary cause of abruptio placenta is not known, but there are different risk factors like those mentioned on the books, like prior abruption, increased parity in maternal age, maternal substance use, trauma, maternal disease like hypertension, and other uterine factors of this. Maternal hypertension, maternal trauma, and previous placental abruption are the most common cause for abruptio placenta. So when we see the pathogenesis on the pathophysiology of abruptio placenta, one of the after mentioned pathogenesis is rapid uterine decompression. So when there is, as we know, placenta is inelastic, so wouldn't be stretched while there is a rapid uterine decompression or there is a rapid uterine stretching. So in that case, placenta, there will be shrink effect. So the decidual area, so vessels will be ruptured. So it's one mechanism of bleeding that we explain abruption, which occur following polyhydramnios, multiple gestation, or during rupture of membrane. Trauma will be explained on with this mechanism of bleeding. The other might be due to suboptimal trophoblastic implantations. Yeah, so optimal trophoblastic implantation due to uterine factors like presence of uterine myoma, scar. So such kind of risk factors might be explained with this one. The other is vasoconstriction due to those patients, those risk factors, those mothers who have risk factors like hypertension, hypertension, those who have history of drug use, cocaine use might be, also smoking can be also cause vasoconstriction and lead to abruption. The other is the abnormalities in the early development of the spiral arteries, also one of the pathogenesis for placental abruption. So all this mechanism of bleeding will lead to residual necrosis, placental inflammation, infarction, and ultimately the vasculatures will be disrupted and bleeding will be ensued. So following the disruption of the residual vessels, there will be release of different factors like tissue factor, tissue factors, and vascular endothelial growth factors will be released and will lead to release of thrombin. So thrombin, the pathogenesis and clinical manifestation of abruption, has a major role for the clinical presentation and pathogenesis of abruption. So one of the effects of thrombin and pathogenesis and the clinical manifestation of abruption is it has a direct uterotonic effect on the uterus, so it will cause uterine hypertonus and contraction. That's why patients with abruption will have abdominal pain or uterine contraction. And the other effect of thrombin, the other effect of thrombin is it will enhance the expression of matrix metalloproteinase that will also upregulate genes involved in the apoptosis and induce expressions of inflammatory cytokines. Commonly, interleukin 8 will be expressed more. So this will cause necrosis of the tissue, will cause tissue necrosis and degradation, and finally also leads to rupture of membrane. It will also cause separation of the placenta more further, and also cause rupture of membrane, and labor will be also initiated. So it will create a vicious cycle in the pathogenesis of abruption. And the other effect of thrombin is that it will decrease the expression of progesterone. So there will be functional progesterone withdrawal, and the uterus also will lead to be tetanic or hypertonus. And the other effect of thrombin, the pathogenesis of abruption, is that it will trigger the coagulation cascade, and finally it will end up with the DIC. So it's good to know the role of thrombin in the pathogenesis and clinical manifestation of abruption. So the clinical manifestation of abruption, it depends on the temporal nature of the abruption. It can be acute one or chronic, it can be also overt or concealed, and it can be also different in the severity of the abruption. But typically, patients with abruption will present with vaginal bleeding in 80% of cases, and they will have also uterine tenderness in 70% of cases, and nourishment fetal status also will be there. So depending on the nature of abruption, so abruption can be an acute one or chronic one. So acute abruption is characterized by with painful vaginal bleeding, and they will have abdominal pain, back pain, uterine contraction will be there, and the fetal heartbeat also there might be fetal heartbeat abnormalities and preterm labor. And pathologically, such kind of abruption will have a central involvement of placenta. The placenta preparation will be in the central area, and the cause of bleeding is arterial one. So the source of bleeding in abruption is arterial hemorrhage. But in chronic abruption, there will be light and chronic intermittent bleeding, and the patient also have liquidominance, fecal growth restriction, preeclampsia, rupture of membrane, and the source of bleeding in chronic abruption commonly is venous one, and it will be found on the periphery of the placenta, not on the central end, not on the from the arterial original legs out of acute abruption. Okay, so depending on the site of bleeding, so there are three sites of bleeding, common sites of bleeding in abruption. One is it can be retroplacental, which is between the placenta and the myometrium, or it can be subchorionic one, which is found between the placenta and the membrane, and can be preplacental. between the placenta and the amniotic fluid, or it can be also called subamniotic. And also there are also it can be the bleeding might be into the myometrium, which is called covular urethra, so it can be even in the amniotic fluid and will cause a post-void appearance. So these figures will show the site of bleeding. So depending on the degree of placental abruption or placental separation, its clinical effect, abruption can be graded into 4. So it can be grade 1, grade 0, or mild. Grade 1, like moderate 1. So grade 1 can be grade 1, grade 2, grade 3. So usually grade 1 is a symptomatic one, and grade 0 is a symptomatic one, and grade 1 is usually have mild symptoms, and those patients who are classified into grade 2 will have moderate symptom, and grade 3 will have severe one. So depending on the patient clinical finding and laboratory results, so they are graded accordingly. So the prognosis of abruption is depend on the site, the severity of abruption. So of those mentioned sites of bleeding, retroplacental hematoma, which is the most common site of bleeding in abruption, will have a worst prognosis for fetal survival, unlike that of the other site of bleeding. And also the size of hemorrhage will also predict fetal survival. So those bleeding which have greater volume or size, like more than 16 ml, will have a greater fatality rate, unlike that of the smallest one. And the other is the other one is severe one. So those abruptions which is severe one also have a bad prognosis. So to say severe abruption, the placental separation is more than 15%, and the mother will have such kind of maternal sequelae like DISP, shock, transfusion, hysterectomy, risk in renal failure or death might be there. If it is severe one, fetal complication, reaction fetal status, growth restriction or death also will occur. So the neonatal outcome also death, preterm delivery or growth restriction. So if we found such presentation, it will be defined as a severe abruption. It has a worse prognosis. So when it is a complication, there are maternal complication and fetal complication in abruption. So the maternal complications are like blood loss, DIC, need for transfusion, organ damage, fetal section rate will be also might be also increased, days, and fetal complications like IGR, oligohydramnios, prematurity, reassuring fetal threat pattern, and stillbirths will be mentioned for fetal complication. So when we see the diagnosis of abruption, so abruption is mostly there as clinical diagnosis and can be also supported by with radiologic, laboratory, or pathologic studies, but since it is difficult to be diagnosed antenatally, so it's a clinical diagnosis. So it's a clinical diagnosis, so it's diagnosed after delivery. So the ultrasound detection rate is almost less than 2%. So that's low sensitivity, but the positive predictive value is around 88%. So we usually try to check the site of bleeding, even if the detection rate is low. So generally, it's a clinical diagnosis. For laboratory finding, you might find hypophycogenemia or evidence of concerted coagulopathy on coagulation profile will be there on serum analysis. Also, there will be elevations in the maternal alpha fetoprotein might be also elevated sometimes. And the other is a pathologic studies. So on close inspection, we might find adherent clot or depression on the placental surface, and histologic analysis also might also identify or diagnose abruption. Okay, so the management is depend on the patient clinical condition, the gestational age, and the amount of bleeding. So the initial approach for all patients diagnosed with abruption is admission. and maternal and fetal monitoring, maternal support, blood product will be prepared, and medications will be administered. So here, after admission, the maternal vital sign, urine output, generally the hemodynamic status of the patient, the mother will be assessed, and the amount of blood loss also estimated, ultrasound for fetal status, and close monitoring or continuous monitoring for fetal status is important in monitoring. And on the maternal support, you should secure IV lines and start resuscitation to with a target of greater than 30 ml per hour for urine output. And the patient should be warmed, and depending on the oxygen saturation, the oxygen might be supplemented. And on laboratory, so laboratory examination, we will send baseline investigations like blood group RH, CBC, the coagulation profile, the creatinine level, and the other investigation, depending on the patient condition, will be sent. And bedside clotting test might be also is important. And finally, blood products should be prepared depending on the need. So if you suspect the bleeding, if there is a if the bleeding is continuing, the estimated blood loss clinical, if it exceeds like more than 500 ml to 1000 ml, we are going to transfuse with blood. So the target for blood transfusion, the target after blood transfusion is to make the hematocrit level greater than 25%, and the platelet count more than 75%, 75,000, and the fibrogen level greater than 300 milligram per day, and the coagulation profile like prothrombin and partial thromboplastin time to be less than 1.5 times control. The other scenario for patients with abrasion who have preterm labor. So if some maternal and fetal status is reassuring, so if there is hemodynamic stability, we are going to administer tocolytic agent, preferably NFD, will be administered until the full dose of antenatal steroids are administered. So those mentioned are the initial approach for all patients. And for patients, then after the initial management, we are going to, okay, so after the initial management, we will decide on the options of management. It can be expectant or delivery. So these are the these are the indications for immediate delivery, like if it is term pregnancy, there is advance in labor, if the fetus is malformed, or if there is a severe abruption like DIC shock, or if there is a need for blood transfusion, renal failure, the fetal status reassuring one, or if there is IFD. These are the indications for immediate delivery. So these patients will not be candidates for expectant management. So delivery will be. So the delivery time for abruption for patients with managed with conservative one, the scheduled delivery will be at 37 weeks of gestation. The vaginal birth or vaginal delivery is a preferred one, and cesarean section is only done for obstetric indication. The other one is hysterectomy. So it's not recommended unless there is uncontrolled hemorrhage with conservative surgical management. So hypertonic agents and conservative surgical management are enough. Even for cochlear interest, hypertonic agents are the best one and the options for the management for cochlear interest. So unless it is unresponsive one, hysterectomy is not recommended. Generally, the mode of delivery for placental abruption is vaginal delivery. Cesarean section is only for obstetric indication. So this picture shows the left side. It will show the gross inspection of the placenta after delivery. You can see the dark one, which is the adherence growth and the depression on the placental surface, which is unevident for placental abruption. And on the right side, it is a uterus, which has color change due to extravasation of blood, extravasation of blood from the placenta into the myometrium. So it's a covular uterus. This is the algorithm for generalized algorithm for management of abruption. So if it is dead fetus, so the management depends on the maternal state, hemodynamic state. So if the mother is unstable, so initially you replace or stabilize the mother and consider cesarean delivery. If it is a mother is stable, vaginal delivery is preferred. But if the fetal status is alive, it's independent on the status of the fetus will be determined the next mode of delivery. So if the fetal status in category 3 or if the mother is unstable, the mode of delivery will be cesarean delivery. If the fetal status is category 2 fetal rate abnormalities and the mother is stable, vaginal or cesarean delivery will be option of management. And for category 1 fetal rate abnormal fetal rate and the mother is stable, the management will be dependent on the gestational age. So if the gestational age is 34 weeks, so conservative management will be initiated. If it is 34 to 34 weeks, 34 to 36 weeks, so biophysical profile, steroids be administered and the timing of delivery is around 37. So abruption occur after 36 weeks of gestational age. So termination will be considered. So the mode of delivery, as we said, is vaginal delivery, the preferable one. So management for future pregnancy. So there will be risk of recurrence in the future pregnancy, and also there will be a high likelihood of low birth weight, IUGR, and preeclampsia on the future pregnancy, and even there is also cardiovascular risks in the future pregnancy. So such patients will need close monitoring and follow-up. And the timing of delivery and the future pregnancy is dependent on the previous history of abruption and the perinatal outcome. So for most patients with one previous history of abruption, we wait spontaneous labor or scheduled labor induction or repeat cesarean birth will be scheduled at 39 to 39 plus 4 weeks of gestational age. And for patients who have had prior more than one abruption or those mothers who have prior history of perinatal days, so the delivery time will be 37 to 38 weeks gestational age. So this one is from this evidence is from the up-to-date, the current up-to-date guideline. So yeah, so the mode of delivery, so the next in the future pregnancies for those mothers who have abruption, so the next timing of delivery will be dependent on the recurrence of the number of recurrence of abruption and the perinatal days and the perinatal outcome. So the other cause of antepartum hemorrhage is placenta previa, which is defined as the presence of placental tissue over or adjacent to the cervical os. So it can be through one or low-lying placenta previa. So to placental previa, the placenta will cover the internal cervical os, But in low-lying placenta, the placenta will be found within 2 centimeters from the internal cervical os, but it doesn't cover the internal cervical os. So this is the current classification for placenta previa. So those cover those placenta which cover the internal cervical os is a true one. But those placenta previa which is found within 2 centimeters from the internal cervical os is low-lying placenta previa. So the incidence of placenta previa, so it is higher in the second trimester, but in term pregnancy the risk will be 0.5% or 1 in 200 deliveries. But in second trimester, the risk of placenta previa, the incidence of placenta previa is around 6%. So there are some theories for such explanation or resolution of the placenta. There are which are mentioned for such changes which occur throughout the pregnancy. So one theory for the resolution of placenta is formation of lower uterine segment. So on second trimester, the lower uterine segments are around 0.5% at 20 weeks. But at term, it will reach up to 5 centimeters. So because of this formation of lower uterine segment, the placenta will relocate away from the cervical os. So one theory is the formation of lower uterine segment, which will be mentioned for the resolution of the placenta. So the second theory is placental-free uterine wall has been proposed to grow at a faster rate than the uterine wall, which is covered by the placenta. So the placental-free uterine wall will grow faster than the uterine wall, which is covered by the placenta. So it will decrease the risk of placenta previa. The other hypothesis is tropotrophism. Here, the placenta will grow away from the cervical os toward the fundus, which results in resolution of the placenta previa. For this, since the blood supply in the fundus is higher than the lower ones, so the placenta will grow towards the fundus to get more nourishment. So because of that, placenta move away from the internal cervical. So these are the three theories which are suggested for such resolution of placenta previa. The exact cause of placenta previa is still unknown, like that of the placental abruption, but there are different theories for the development of placenta previa. One is a dropping down theory here, when there is poor decidual reaction in the upper uterine segment because of presence of fibroids, uterine scar. Because of that, if there is poor decidual reaction in the upper uterine segment, so the fertilized ovum will drop to the lower uterine segment and implanted there. So one theory is a dropping down theory. So those dropped ovum will implant in the lower uterine segment. So it will cause placenta previa. The other is persistency of chorionic activity on the decidua capsularis. The third one is defective decidua. Here it will, so if the decidua is defective, so the placenta will not be there. So it will try to find more nourishment from the uterus. So it will spread its chorionic villi over a wide area on the uterine wall to get a nourishment. That's why those patients who have a scar might develop placenta previa. So the placenta will encroach to the other areas which have more nourishment than the defective one. The fourth theory is the placental big surface area. So presence of big surface area of the placenta also one of the etiology theoretically which cause placenta previa. This might be explained with multiple gestation or infectious causes will be explained with this theory. So as a risk factor, so prior placenta previa, prior history of cesarean delivery or uterine surgery, increased maternal factors like increased parity, advanced maternal age, race, extrinsic maternal factors like smoking, cocaine use, assisted reproductive technology, and fetal factors like multi-male fetus and multiple gestation. These are the risk factor of this commonest one. Commonly, those mothers who have prior history of placenta previa or uterine surgery or cesarean delivery or some uterine scar have a higher risk of placenta previa. So this table will show us risk of placenta previa after depending on the number of cesarean delivery. So generally, in the general population, the risk of placenta previa, as we said before, is 0.5%. As the number of cesarean delivery increase, the risk will reach up to 10%. And even the risk of placental adherence also increased. So the clinical manifestations, so patients presented with sudden, painless, and causeless recurrent vaginal bleeding on the second half of pregnancy. And around 70 to 80% of patients will have at least one episode of bleeding. Of those patients, 1/3 will present before 30 weeks of gestational age, and 1/3 will be presented between we will have an episode of bleeding between 30 to 36 of gestational age, and 1/3 will have bleeding after 36 of gestational age. And around less than 10% of patients will remain asymptomatic until. So patients with placenta previa, as we said, they will present with bleeding commonly. So why they develop bleeding? One of it is the formation of lower uterine segment. So when there is a formation of lower uterine segment, there will be a risk of bleeding. The other one is presence of uterine contraction. So when there is uterine contraction during labor, when there is cervical dilatation and effacement during coitus and during digital pelvic examination, will increase the risk of bleeding in placenta previa. So such things should be avoided in patients with placenta previa. So for patients presented with bleeding after 20 weeks of gestational age, unless you ruled out placenta previa, other diagnosis should not be put. So for such patients, the first diagnosis should be placenta previa. Then after you rule out placenta previa, you can diagnose the other cause of abruption and the other cause of APH. So how do we diagnose placenta previa? It's diagnosed by ultrasound. So the sensitivity or the detection rate is higher. So we can diagnose by ultrasound. So can do transabdominal or transvaginal ultrasound, and the sensitivity of the diagnostic accuracy of ultrasound for is 100% for transvaginal ultrasound, and for transabdominal ultrasound, the accuracy rate is around 95%. So generally, we can use a combined approach, like first you will use transabdominal, then you can proceed to the transvaginal ultrasound. So if you diagnose placenta previa or low-lying placenta previa on second trimester, it needs serial ultrasound evaluation. because of the previously mentioned theories, more than 90% of cases of placenta previa, which is diagnosed on second trimester, will resolve by term. So they need serial ultrasound evaluation. So such resolutions depend on the timing of the diagnosis. So those diagnosed earlier, so will have more resolution. So if it's diagnosed like in second trimester, the resolution rate will be higher. It is persisted or throughout the third trimester, so the persistency of placenta previa will be higher. And the other is the extension over the cervical os. So those placentas which cover the internal cervical os have a high risk of persistency, so less likely to be resolved. And depending on the placental location, those placental belt which is found on the posterior uterine wall will have a higher resolution rate than the anterior. So depending on that, those placenta previa diagnosed on second trimester, they need serial ultrasound evaluation because more than 90% will have resolution. The place of Hemorrhage for diagnosis of placenta previa. So we will prescribe Hemorrhage, will send Hemorrhage if your ultrasound finding is equivocal, if the placenta location is posterior one, which is difficult to see face ultrasound, or if you suspect equivocal diagnosis for placental adherence, in such cases we will send MRI. So otherwise, ultrasound is enough to diagnose placenta previa. Thus, it is equivocal. So these are these are the sonography ultrasound features, which is associated with higher likelihood of bleeding. So those placenta which cover the internal cervical os completely will have high risk of bleeding than the low-lying one. Those placentas, those placenta edge which have more than 1 centimeter thickness, also the risk for bleeding. In the presence of echo-free space in the placental edge, in the presence of short cervical lengths, a risk for increased likelihood of bleeding. So these are the ultrasound features which shows high risk of bleeding in patients with placenta previa. So this image will show us the left side, so you can see the cervix, the transvaginal ultrasound report. So you see the cervix, internal cervical os, and the placenta. So the placenta, as we see it there, it will cover the internal cervical os totally. So it is true placenta previa. So the management, those placentas previa, as we said, it's around 10%, will not have any bleeding, even throughout the pregnancy. So those asymptomatic patients need serial ultrasound evaluation. And we need also to rule out placental accreta spectrum. And also the risk of bleeding should be minimized. So as we said it before, in placenta previa, risk of bleeding will be increased if you do PV examination, if you had coitus, if you start to have labor. So at least those iatrogenic causes should be minimized. And then we'll decide on the place of inpatient or outpatient management for asymptomatic patients. So there are some patient risk factors which need to be considered to decide on the patient admission for the asymptomatic placenta previa. So those mothers who have short cervical length, like less than 25 centimeters, 25 millimeter. So such mothers, and the other is those mothers who have rapid cervical shortening, like more than 10 millimeter shortening over 1 or 2 weeks on transvaginal ultrasound, and inability to get the hospital immediately, like within 20 minutes, and lack of home support in case of emergency. And those mothers who couldn't understand the one that she's advised, such patients should be admitted and managed accordingly. And the timing of delivery for such patients is around 36 to 37 weeks of gestation, even if asymptomatic. And during this time, you will follow them with the APH chart, and also the place of magnesium sulfate for neuroprotection, the place of steroids. It's a controversial for asymptomatic placenta previa, so it should be a shared decision with the mother. The second, other management for acute care, those mothers who have symptomatic, those who have bleeding should be admitted, and the maternal hemodynamic status should be followed. The fetal assessment, the fetal status also should be monitored and assessed, and baseline investigations should be sent. Blood banks should be also notified to prepare blood products, and the mother should be stabilized. Magnesium sulfate for neuroprotection should be administered for those mothers with gestational age less than 32 weeks of gestational age. Antenatal steroids also should be administered, and anti-D for those mothers who are Rh negative administered. And the place of thrombolysis for patients or symptomatic patients. Here, thrombolytic agents can be administered if the bleeding is minimal or ceased. So in such patients, we can consider thrombolysis until we administer antenatal corticosteroids. Otherwise, we don't arrest labor or unstable or hemodynamically unstable or reaching fetal heart rate status. Then after, we will decide whether to follow them conservatively or whether to deliver them immediately. So these are the indications for immediate delivery after stabilization, like being term, IVD, IVGR. If there is significant vaginal bleeding after 34 weeks of gestational age, there is hemodynamic stability, which cannot be achieved or maintained with stabilization. There is gross fetal malformation, which might not be compatible with life. If there is labor, these are the indication for immediate delivery. So such patients are not a candidate for conservative management. Rather, delivery is the option of management. So the timing of delivery is between 36 to 37 weeks of gestational age. So generally 36 to 37 weeks. So after 36 weeks of gestational age, it's better to deliver them. But in our guideline, when they reach to term, or if there is any sign of, or if there is any indication for immediate delivery, so the delivery process will be initiated. Okay, the route of delivery. If there is obstetric indication for cesarean delivery, or if there is placenta, if it is placenta previa, which covers internal cervical loss. If it's low lying and if the placental distance from the internal cervical loss, it is less than 10 millimeter. These are the indication for cesarean delivery. Otherwise, for low lying placenta previa, which the placental age greater than 1 centimeter and less than 2 centimeter for such patient. The mode of delivery is vaginal delivery. So the other obstetric indication, the presence of placenta previa and low-lying placenta, the distance between the age of the placenta and the internal cervical is a bit less than 10 millimeter. They are an indication for cesarean delivery. Otherwise, those mothers who doesn't need any indication or any those mothers who doesn't have any indication for immediate delivery are followed conservatively. This is the algorithm. So if they are asymptomatic, we will consider antenatal corticosteroids at 34 to 37 weeks of gestational age and delivery at 36 to 37 weeks of gestational age. If they are symptomatic and maternal and fetal status is stable, we will administer steroids, magnesium for neuroprotection, and delivery will be considered by 37 weeks of gestational age. Or if there is indication for immediate delivery, we will consider immediate. For those mothers who are symptomatic and unstable, those maternal and fetal status will be stabilized and delivery should be initiated after you stabilize the mother. So this is a general algorithm for placenta previa. This is the distinguishing features for placenta previa and abruptio placenta. Clinical features, abdominal examination, the ultrasound findings, and vaginal examination finding. So those patients, those mothers who are diagnosed with placenta previa, they will have paleness, as we said, and causeless and recurrent bleeding, and the bleeding usually revealed. So we can see the bleeding. And the amount of the blood loss is proportional to the patient's hemodynamic status. And the bleeding characteristics are the characteristics of flight rate. And for abortion, they will have painful bleeding, and the bleeding might be revealed or concealed one, or it can be mixed, or revealed or concealed one. And they will have an associated preeclampsia or trauma or other conditions. And the blood is dark one. And the amount of blood loss in placenta abruption is not like that of the placenta previa. It's not proportional to the maternal hemodynamic status. So it will be out of proportion to the one that you are visible for your naked eye. So since there is a concealed one, which is not be visible on you closely, but the patient hemodynamic status will be affected. So the blood loss is not proportional to the patient's hemodynamic status. In patients with abruption, as we said, preeclampsia is one of the most common risk factors for abruption. So features of preeclampsia usually will be found on abruptio placenta. On abdominal examination, the height of the uterus or the fundal height will be proportional to the gestational age in placenta previa. But in abruptio placenta, it might not be proportional, and there will be tenderness or contraction. And in placenta previa, there will be malpresentation and high head floating. The fetal erythroid status or the fetal condition will be normal in placenta previa, but in abruption, usually it can be affected. On ultrasound, the placenta is a low uterine segment in placenta previa, but in our option it's a fundus. So the vaginal examination finding, as we said before, we couldn't do placental vaginal examination in placenta previa patients. But if normally it's found on the lower uterine segment. In our option, we couldn't found the placenta on the internal cervical, also on the lower uterine segment. So these are the characters, the differentiation mechanism for placenta previa and placental abruption. Just to mention some associated condition APH patient is. One of this mentioned is placenta, morbidly adherent placenta. So it's an abnormal placental attachment. There are different classifications, and the most common risk factor for such kind of patients are previous history of uterine surgery and clinical manifestation. Maybe they will have bleeding during pregnancy, but commonly this kind of condition usually will have torrential bleeding when we try to separate the placenta during the delivery. Otherwise, during the antenatal period, they might be asymptomatic, or they may have bleeding like that of the placenta previa. So there are different diagnostic methods like ultrasound, lab findings, pathologic studies will be there in the management. Also, I will try to mention on the next slides. So these are the classification. So this is the gross finding of morbidly adherent placenta. So on the first picture, the placenta is adhered to the myometrial wall. On the second picture, the placenta will encroach into the myometrium. On the lower picture, the whole layer of the uterus is involved, even the serum is also involved here. This is a morbidly adherent placenta. These are ultrasound features of morbidly adherent placenta. So on ultrasound, you might see the loss of the normal hypoechoic retroplacental myometrial zone. There will be thinning of the uterine wall and disruption of the normal uterine serosine blood wall interface. We might find exophytic masses within the placenta, or there might be numerous intraplacental vascular leakiness will be found inside the ultrasound features of the morbidly adherent placenta. These are general management algorithm for placental accreta syndrome. So there are some prenatal cares like correction of nutritional anemia, antenatal corticosteroids, magnesium for neuroprotection, and during the delivery process. Since it is a multidisciplinary one, so different professionals will be involved. IV access should be maintained, secured, their products should be available. So after doing that, again, the delivery process. So the mode of delivery is, as we know, it's a cesarean section. And depending on the adherence, so might be conservative or uterine preserving surgery can be done, or hysterectomy is a definitive management in the postpartum care. Such patients risk of hemorrhage, shock, they might need intensive care management. So our last topic is vasa previa, which is one of the cause for antepartum hemorrhage. So vasa previa is defined as the presence of fetal vessel over the internal cervical os within 2 centimeters. Here it's not a placenta previa, rather it's not a placenta that you are found on the lower around the uterine cervical os, rather you will find fetal vessels with or without the fetal membrane. So there are two types of vasa previa, type 1 and type 2. So in type 1, normally the umbilical cord will insert into the placenta centrally. But in velamentous cord insertion, the umbilical cord will not insert into the placenta. Rather, it will go through the membrane. That is type 1. So in type 2, the vessels, so these vessels will connect to the bilobed or accentuates lobed placenta. So these are the two types, and such kind of condition. Normally, the fetal placenta have protection from Martingales. So here, there is no protection from Martingale, and the vessels will be at risk for bleeding and rupture. Especially these patients presented after rupture of membrane. So if we look at one in 2,500 deliveries, and the risk factors like bilobed placenta, pregnancies is from the assisted reproductive technology, multiple gestation, history of low-lying or placenta previa, the risk factor for vasa previa. In the clinical manifestation, so most of them will be identified when you found vaginal bleeding after delivery, after rupture of membrane. So immediately after rupture of membrane, you found rupture of these vessels are not protected, and they are found on the internal cervical os. Once the membrane rupture, they are at risk of rupture and cause torrential bleeding. And this patient need even close follow-up, and the fetus also might be at risk for anemia. And they are diagnosed with ultrasound. So here, as you see, the placenta normally inserted centrally, but in velamentous one, the placenta will insert, the cords will insert into the membranes, not on the placenta. In the fetal, these vessels will even goes through the membrane, even for long distance. So they are at risk for rupture and torrential bleeding. And the image on the lower shows ultrasound features of vasa previa. So as you see, a cervix is found there in the vessels. So the color Doppler, the vessels will be found on the lower uterine segment or in the internal cervical. So once the membrane ruptured, they are at risk for bleeding. So it can be transmitted. So as I said before, it's diagnosed with ultrasound. If you found umbilical vessels over the cervical os on the color Doppler, you can diagnose vasa previa. In the management, I need admission at 28 to 32 weeks of gestation. It's asymptomatic, and delivery is most recommended mode of delivery is cesarean delivery between 34 to 37 weeks of gestational age. And if it is diagnosed antenatally, they are managed like that of placenta previa. But if you diagnose it intrapartum, well, patient starts to have labor, so fast delivery is important. And the risk of bleeding is, since it is higher, so the neonate might be at risk for neonatal anemia and need blood transfusion. So thank you for being with me. Antepartum hemorrhage, it's a commonest obstetric hemorrhage. There are different causes of obstetric hemorrhage will be mentioned, but commonly we face the two one. So abruption in placenta previa is the most common cause of antepartum hemorrhage that we are going to be find during our attachments, neural attachments. So it's better to know them, differentiating mechanism, the commonest risk factor for each, and the common clinical features, and the diagnostic method, and the general approach of management of such kind of patients. And thank you.
All right. Thank you very much, Dr. Getnet. It was quite insightful. We took quite a little bit of time, and because the time is running late, we can address one or two questions if there are any from the participants.
I think I couldn't see questions on the chat box, but generally for patients with antepartum hemorrhage, generally as a bleeding patient, you need to follow the APC of life, but there are supportive managements and specific management for each condition. So general management for antepartum hemorrhage. So you will admit, you will take their vital signs, you will secure IV lines, you will start resuscitation, and blood investigations will be sent, and cross-match blood products should be available at hand. Our material should be prepared at bedside, and fetal status and should be followed with continuous monitoring if it's available, or ultrasound. And after you stabilize both the mother and the fetus, you will proceed to specific cause-specific management. So the cause-specific management are mentioned. So for placental previa, you will manage accordingly. For abruption, you will manage accordingly. I think I'm seeing one question. In a patient with placenta previa, low-lying placenta previa, less than 10 millimeter and IFD, is CS still indicated? But here, the main fear, even if it is an IFD, the main fear is bleeding. So the mother might be at risk for bleeding. So when we are trying to initiate the process of vaginal delivery, and if the placental age is the lower, like less than 10 millimeters from the internal cervicalus, it's better to go with cesarean delivery, even if the fetal condition is IFD, just for the sake of the mother.
All right. Okay, one last question. So it is, how is the mechanism of tocolytics and relation between being hypothyroidism with APH? So I think two questions. How is the mechanism of tocolytics? And the relation between being hypothyroidism, the relationship between hypothyroidism and APH.
Okay. So generally, for the main objectives of tocolytics is to suppress uterine contraction. So there are different options of tocolytic agents. There are different options of tocolytic agents, but here usually we use like magnesium sulfate, nifedipine can be used, and because their mechanism of action generally by blocking the calcium channel blockers, by blocking the calcium channel. And the relation between hypothyroidism with APH, normally I try to search such relationship with antepartum hemorrhage, but the risk of antepartum hemorrhage in patients with hypothyroidism is rare. But commonly, those patients, those mothers who have hypertension, that is the most common one, which is mentioned for APH patients. Maybe I will try to dig out further for this question. And I couldn't get clear association with antepartum hemorrhage. Even on the standard book, it says rarely associated with hypothyroidism.
All right. So, Dr. Getnet, on behalf of Blue Health Ethiopia and Latinat, as well as all our participants, I would love to thank you for taking the time and presenting the 95th Blue Health Virtual Seminar, which was presented with the sponsorship of Latinat. Thank you, and we hope to have future sessions with you with similar or related topics as well. And I also would love to thank all the participants for being patient for the network inconveniences in the middle and at first as well. And Dr. Getnet, if you have anything that you would love to address at last, please let me give you the stage one more time.
Okay. I think this one is one of my first webinars to present. And thank you, Blue Health and Latinat, for giving me the chance to share my knowledge and experience. And thank you, participants, for your active participation and for your patience for network and problems. So generally, I would like to thank all the teams, Blue Health teams, for coordinating and preparing such kind of presentation for our audiences. And thank you so much.